a kind reminder to be made. Now you can access to our book of abstracts and book of proceedings by scanning the QR code mentioned in your event tags. Moving on to the next segment today, that is a guest lecture in safe prescribing in pregnancy. May I call upon Dr. Varsha D'Souza and Dr. Kolitha Jayasundara to chair the session.
Right. I'm sure you recognize I'm not Dr. Varsha D'Souza. I'm Arosha Disanayaka. Varsha is indisposed at the moment, so I'm just stepping in, replacing her. Anyway, it's my great pleasure to invite the next speaker, my very good friend, Dr. Nandana Dickmadugoda, and his CV is still not on. Dr. Nandana Dickmadugoda is a very senior academic colleague and a very senior internal medicine physician in Sri Lanka. He is a consultant physician. He has served in many important hospitals in Sri Lanka. And then currently he is in Colombo South Teaching Hospital, and he serves in General Hospital, Navy, Vadisara as well. Without taking time, I would invite my dear friend Nandana to start his and deliver his lecture. Thank you.
Thanks, Prof. Arosha. Good afternoon. At the outset, I must thank our President, Dr. Kumudini, and the Council for giving me this opportunity. I am currently working in the Colombo South Teaching Hospital as consultant physician in internal medicine, but I worked in Castle Hospital for 4 years. So, in next 20 minutes, I just want to discuss the safe prescribing in pregnancy. Actually, 5 years back in SIMCON, we had a similar lecture on prescribing in pregnancy. So why we are again repeating it, the importance. Then physician's perspective, we had the lecture from the pharmacologist point of view 5 years back. Then there are two concepts we have to talk about, teratogenicity and the pharmacovigilance, and whom we should consider when we think about this safe prescribing. And there are safety categories and the common conditions we encounter as physicians, then the problems associated. Then finally, some key messages or take-home messages for the physicians. So importance, you know that pregnancy, we handle 2 lives. So if the mother is exposed to certain agents, congenital malformation can occur. The drugs can be toxic to the mother or the fetus or both, and it can cause teratogenicity. The teratogenicity is highest in the first trimester, but remember this, the 3rd to 11th week is the highest risk period. What about the 2nd and 3rd trimesters? Still it can cause growth or functional development issues. There are some effects actually manifest after later on life of the child. The good example, if the mother is exposed to diethylstilbestrol, after the puberty, the female child can get the adenocarcinoma of the vagina. Then this new specialty, actually it's not new to us. It's a very old one in the other countries. The obstetric medicine, physicians are involved in handling the obstetric patients. So we are using this one. Actually, this book was written by a professor of obstetric medicine in UK. So this was actually a survival guide for us when we work in obstetric wards as physicians. Okay, right. I think everybody can identify this photo. There are 5 kids. Anybody have any idea? With short arms, what we call phocomelia. So we can't talk about this teratogenicity without talking about the thalidomide. If you read about this thalidomide, it's a very interesting story. That is the biggest man-made medical disaster. Currently, we are experiencing the biggest pharmaceutical scandal in our country, the immunoglobulin. The biggest man-made pharmaceutical scandal, 50 years commemorated in 2016. It was in 1950s to 1960. The drug thalidomide was used for anxiety, poor sleep, and tension, and especially for the morning sickness. This was sold over the counter, so most of the pregnant women took it. Actually, it was done by this Gruenthal company. The person was Kemi Gruenthal. Later on, they were charged for this one, but for years there were no results. First affected baby was one of his company's employees' child. He was given freely, then the mothers were taking and had this thalidomide babies. So it said that more than 10,000 babies affected. Actually, the numbers may be bigger than this, and 40% died at the or shortly after the birth. The survived babies had limb, eye, urinary tract, or heart defects. So the dark cloud of thalidomide had a silver line. What was that? After that, there was this litigation, class actions, compensation, and yellow card systems. More rigorous control over the pharmaceutical products came into play after this thalidomide. The nice thing is that thalidomide, they have tested for mice, the animal studies, but it did not happen any side effects. Its effect only in the human. So the different species act differently. That came into play. But another thing is thalidomide, the chemical compound, there are two isoforms. Only one isoform is working on this defect in the angiogenesis. So the drug, and they have not tested any for the pregnant women on their trials. So that was the story. Then physician's perspective. So we are encountering the different medical conditions, pregnant mothers. They have chronic NCDs, and the number of elderly mothers are going up. And use of multiple drugs, recreational drugs in females, especially alcohol. The loosening of the alcohol-related laws and the social media explaining the alcohol is not very harmful, has played a role in increasing the number of females consuming alcohol. Most of the time, pregnant mothers, they withhold their treatment for medical conditions. The illness can worsen, and there's a risk to the mother and for the baby. Then we should know the benefit and the risks. So we get the referrals from Oxfords. We should know how to use the drugs and different stages of pregnancy, how to use it. We should have a knowledge on teratogenicity of the drugs. So the teratogenicity is the ability to cause structural or functional defect in babies, the fetus, when the substance is taken by the mother. So there are 6 principles. I will not go for the details. The genetic susceptibility is there. So the teratogenicity will not happen in each and every mother, and the development stage will be affected, and there are mechanisms, different mechanisms, either genetic changes or vascular angiogenesis changes like that. Then there are endpoints, what will happen like thalidomide babies, phocomelia or amelia. Then the access means you get the drug or the agent to the mother. Now X-rays might cause problems, might not cause like that. Then the dose response. So we should know this in the teratogenicity. So to prevent teratogenicity, there is a concept called pharmacovigilance. So basically pharmacovigilance is the drug safety. The WHO definition is the science and activities relating to the detection, assessment, and understanding and prevention of adverse effects or any other drug-related effects. Especially, we should be able to identify and evaluate previously unreported adverse reactions. So in my usual working day, I'm working in Kalboil Hospital. So this is my female ward. So I start female ward rounds. So when I enter into the female ward, there are things I have to be mindful. All fertile females are pregnant unless proved otherwise. But this is not my slogan, this is my obstetric professor's slogan, right? So if you think like that, then you are safely prescribing. Is it only for the females? No, in the male ward. What about the males? The male patients also, we have to think about the prescribing. You know, there are drugs that can cause the semen, sexual function. So it's out of this topic. So when we have to consider prescribing for fertility of the men as well. How can we achieve that? So there had been these safety categories since 1979 from the FDA. There are different categories. The category A is the less risk of the drugs we can use in first trimester. The thyroxine, folic acid, multivitamins like drugs. Then the B, there are no risk proven in human studies. The animal studies have shown some adverse effects. Those drugs are penicillin, cephalosporin, metronidazole, nitrofurantoin, and diadenosine. Then the category C, the animal study, shows teratogenic effect, but inadequate in human studies. This group includes mebendazole, acyclovir, chloroquine, and lamotrigine, but still we use in pregnant mothers. So the D, the drug benefit may be beneficial more than the risk. Sorry. The potential risk in humans, but if it is a life-threatening condition or severe disease, we use. Antiepileptics are one example. The X is the absolutely contraindicated group. At least if you know this one, we should not prescribe to a possible pregnant mother. The alcohol, androgens, vitamin A, lithium, radioiodine, cancer chemotherapeutic, tetracycline, and even the thalidomide. You know that thalidomide nowadays also used for multiple myeloma and rheumatoid arthritis. So if you are using in such patient, we have to be cautious. And there's another drug explained as ISED group, which is not categorized or contraindicated, but it's not in the FDA list. Actually, this was the old system of classification. Then the FDA came up with a new categorization, what you call a pregnancy lactation labeling rule. The idea is to implement from 2015 to by 2018 to finish and take out that A, B, C, D, X categorization. The over-the-counter list is not a change, and they have the updated information that has to be supplied by the manufacturer for each and every drug. So why they are using this? That is to actually remove some of the uncertainty on this ABCD categorization and the remove potentially confusing this category and narrative structure on evidence-based data. So this is the one they included as pregnancy, labor and delivery, nursing mothers, and even the females and males of reproductive potential also included in their different categories. If you read the PLLR categorization, you can understand it. Right. So in UK, there's this teratology information service. So you can contact them like our poison center. So the NTIS, earlier term, the National Teratology Information Service. Now it is UKTS. So you can go to the web and check it, and USA, there is another one, TERIS, the Teratogen Information System. They have a data bank, so with 4 sections, including the drugs that can cause congenital anomalies, then the adverse pregnancy and neonatal outcomes, then neurodevelopmental outcomes, and animal teratology studies. Those details are there. If you go to the site, you can see. But Sri Lanka, we don't have such database. I think it is the best time to start it. So I just talk about few common conditions when we prescribe for the pregnant mothers. The drugs or prescription, what are the things we have to consider? In hypertension, mothers, they can have either pregnancy-induced hypertension or the previously diagnosed hypertension. All of you know that ACE inhibitors and ARB is X category, we can't give. Even atenolol, propranolol, and thiazide, they say not to give. And spironolactone also in the D category. HCT again C category. So we can use the labetalol in mothers with hypertension. That is the most of the time first line drug. Methyl dopa, alpha blockers, calcium channel blockers, and hydralazine. All this labetalol and hydralazine, we can use IV as well as oral forms. In epilepsy, the valproate, that can cause fetal valproate syndrome, and the carbamazepine and phenytoin, that can cause fetal phenytoin syndrome. So those are better to avoid. The lamotrigine and levetiracetam, we can use that is the C category. But in epilepsy, I think it's a joint decision of neurologist and physician. If the mother is controlled the seizures with one of these, even the non-recommended drugs, sometimes we use them. So that is a collective decision with the neurologist. Then the hyperthyroidism, in the first trimester we use propylthiouracil. It has the side effect of maternal hepatotoxicity, but we use in first trimester. Then after the first trimester, we can use methimazole or carbimazole. If you use that in the first trimester, there is a chance that you can get choanal or esophageal atresia in the fetus. When about the diabetes, either gestational or pregnancy, the previously existing diabetes, the usual oral forms are metformin and glyburide also. I think there were some trial, but it's not been used much. Metformin is used commonly. In some countries, they don't use metformin at all for pregnant mothers. Sulfonylurea can cause fetal hypoglycemia and we don't use it. These newer therapeutics in the diabetes, the DPP4, pioglitazone, EMPA, they are not recommended because the lack of data. You know that we can't do the trials on pregnant mothers, so there are no enough data to use them. SGLT2 inhibitors, that can cause increased miscarriage, so we don't use it. So the insulin, we can use the aspart, Lispro, and Detamir. And the inhaled insulin and degludec, glargine, and glulisine is not recommended. I think again, depending on the evidence, not much evidence for these preparations. Then the infection, it is a common finding. You are getting a pregnant mother for the infection. So antibiotics, we can use safely, penicillins, cephalosporin, and clindamycin. The amoxicillin clavulanic acid, common antibiotic we are using, that can cause adverse effects on the fetus. Usually we don't use in the first trimester. Some use this, but some recommend not to use. The drugs, the antibiotics which are not used in pregnancy, the tetracycline and streptomycin. Tetracycline can cause bone defects in the children, so better not to use that if you have the chance of using it. Then the antivirals, the antiretroviral, most of them are group C, lamivudine, sidovudine, and lipinavir, and all the other antiretroviral drugs, emtricitabine, tenofovir, and atazanavir, they are B, and we can use them. So if you get a mother with HIV, we can use this antiretroviral treatment and even antivirals. Acyclovir, you know that we are using in pregnant mother with varicella, so we are using that. Antifungal, the itraconazole is contraindicated, better not to use in antifungal in pregnant mothers. Long-term antifungal anyway not indicated, even the terbinafine and amphotericin. So you can use local and vaginal preparations antifungal. Then the dyslipidemia is a common problem we encounter. Most of the young patients, young girls, ladies get this dyslipidemia. So in the pregnancy, there is an increase of cholesterol, total by 50%, LDL by 30 to 40%, HDL 25%, and triglyceride 2 to 3-fold. If you do the lipid profile, and usually we don't recommend them to do the lipid profile. If they do it, they will be worrying about the lipid profile. In pregnancy and lactation, we don't recommend because the statin cannot be used in pregnancy. Fenofibrate, the group C category, but it's not used because there is no enough data. Ezetimibe also, there are no enough data, but some recommend, usually we avoid it. So only the therapy we can do is lifestyle modifications. And if there is severe hyperlipidemia, apheresis of blood has to be done. So the anticoagulation, the warfarin, you know, avoid in first trimester and 2 to 4 weeks, and we can use the heparin. So the painkillers, NSAIDs, better not to use. It can cause the renal infection in the fetus. Opioids also, we don't use, and the drugs we are using to control the opioid, medication of opioid use disorder, we can use methadone and buprenorphine. So with the constraint of time, I'll just write this fetal alcohol syndrome. We should know that I said most of the females, the number of females taking alcohol is going up. So there can be this fetal alcohol syndrome. Most of the facial abnormalities will happen. Not only facial, they get cardiac, skeletal, renal, ears and eyes, and there are so many defects. So these are the facial features of fetal alcohol syndrome. And this warfarin embryopathy, which is called Sala syndrome, again the babies will get facial deformities. Then the interesting thing is about this leflunomide, which is used in the rheumatoid arthritis that can last in the plasma for 2 years. So it can again cause so many abnormalities in the fetus. Now if a mother only leflunomide comes, what can we do? There's something called this cholestyramine washout. We can do it and do the levels in 2 occasions, 14 days apart, and if it is free, only then we can use them. The mother can, the lady can become pregnant. So otherwise, we recommend them not to be on, if they are on leflunomide, better to avoid pregnancy. Right. So male, again, I'm not going to talk about much this thing. I said the sperm count, the sexual function, everything can be affected by the drugs. So we have to be mindful about prescribing in males as well. So most of the drugs can affect the male fertility. Finally, the rules of thumb for the physician. All the fertile females are pregnant unless proved otherwise. So when you prescribe, remember this. Prescribing in males can affect fertility. That also we have to think of. Then no prescription in pregnancy, especially in the first trimester. If possible, that is the best rule. If prescribing, then you should have the information on teratogenicity. And there's this myth that you use the lower dose, but in mothers, you know, the renal and liver clearance is increased. Usually they need a higher dose to get the therapeutic effect. So not to use the lower doses. Then we balance the risk and benefit, then monitor for adverse effects, if any, prescription given to a mother. Then you should take the need action for any adverse effect detected. So I finished there, then thank you.
Thank you. Since we are running out of time, we will not have questions after this talk. Thank you very much for a very comprehensive talk. May I invite my co-chair, Dr. Kolita, to hand over the certificate of appreciation, please.
Thank you very much, sir.